Everybody. Thank you so much for joining our coffee conversations this morning. I am here with Dr. Shoemate, and we are going to have an Ask the Expert session. And during this session, we're going to be talking about breast surgery. So, Dr. Shoemate, I'm so glad that you're here with us today. If you could just kind of tell us about you.
Well, I grew up in Tuscaloosa. I got my undergraduate in medical education through the University of Alabama. Subsequently, I spent 5 years in Louisville, Kentucky, and then 2 years in Houston at the MD Anderson Cancer Center before coming back here in 1991, where I started a practice in surgical oncology. It was a broad general practice of surgical oncology. Eventually, it developed into one where most of what I did had to do with the diagnosis and treatment of breast cancer.
What drew you to want to be involved in oncology and breast cancer?
I think it had to do with the fact that there was a lot of interaction between different specialties. Surgery, chemotherapy, radiation therapy are all used to treat cancer. And with most cancers, it does take a multidisciplinary approach to get a good result. And nowhere is that more evident than in breast cancer.
Well, thank you so much. I know you've helped many people throughout your career, and we're just so excited to be connected to you here at Forge. So, diving right into it, could you just kind of lay out a little bit of the history of breast cancer, not breast cancer, but breast surgery?
If you look at breast cancer treatment, it's been around for a long, long time. But the modern history of breast cancer surgery really started in the late 1800s and the 1880s, when the radical mastectomy was popularized and became basically the standard of care until the 1960s. Big operation, takes the breast, the chest wall muscles, all the lymph nodes underneath the arm, as well as sometimes lymph nodes within the chest. And at the time that was developed, it was necessary. There was no staging or grading system for breast cancer. There was no imaging that you could do. Lady came in with an obvious cancer in the breast, and that surgery needed to be done. Over time, however, it became evident that breast cancer was not just a local and regional disease, but also often a systemic or whole body disease. By the 1960s, the radical mastectomy was challenged. And over the ensuing 20 or so years, things moved from a radical mastectomy to a modified radical mastectomy, which means you just remove the breast and lymph nodes. That developed into breast conservation surgery, commonly called a lumpectomy, with radiation therapy and removing the lymph nodes underneath the arm. And all these things made things better. Survival was better, cosmesis was better, function was better. And at the whole time that you were doing less surgery, you were really achieving as good or better outcomes for the patient. Fast forward to where we are now. Frequently, a lady has a needle biopsy for diagnosis. Recommendations are given for lumpectomy and radiation or mastectomy. Mastectomy is considered with or without reconstruction, which can be done immediate or delayed. There's a whole host of things that are available now and options that are available. In ways that's good, in other ways it can be overwhelming. You tell a lady that she's got breast cancer, suddenly the wheels start turning, and she's wondering a lot of things. Am I going to live? Is going to take care of my kids? What's going to happen to me? So it's important for women to realize these days that there are a lot of options that are out there. Everyone's planning on you living a long, happy, healthy, disease-free life afterwards. So there's nothing wrong with taking some time to go through your options, consider what all is necessary, what can be done for you, and choose the best options for what you prefer, as well as what's oncologically sound.
I love that you pointed out that there's time, because oftentimes, like my mom was diagnosed with cancer, and immediately you think about like, I need to do this, I need to do that, I need to do this, I need to do that. What's the next step? But at times it can be very overwhelming for some, and they still think that even though I'm overwhelmed, I don't know what's going on, I need to make a decision now, and not even really kind of exploring what that means, what that feels like, what options there are. So I love that you pointed out you have time to decide those things. You don't have to make the decision tomorrow in most cases. So when somebody is, exploring this option for throughout their treatment, what are some suggestions you have to those who just don't know where to start?
I think the most important thing to realize is that breast cancer has a long tumor doubling time, which means it takes a long time for one cell to become 2 to 4%. And as a result, there's a window of opportunity there not only to find the breast cancer, but also to explore your options of what needs to be done. So it's one of those things where as soon as you get the diagnosis, a lot of people want to run out and do something immediately. They think that that's what they have to do in order to survive. Well, in fact, it's not. You've got time to explore these options with your doctor. You've got time to get all the necessary radiological studies that will help your doctors make the decision about what's best for you and help you make the decision what's best for you. Quite often, this decision-making process is going to involve the surgeon, a medical oncologist, chemotherapy doctor, radiation doctor. If you're considering reconstruction, you'll need to see a reconstruction surgeon as well. So all these things take time to unfold and develop. And then each step of the way, more information is obtained, which enables you to go further. So I'm not advocating putting this off for months. The human mind just can't tolerate that very well either. But by the same token, you've got days and weeks to make your decision, to accumulate the information you need to make that decision. And I would encourage everybody to take their time to do that.
Yeah, I think that having more information is power, like knowledge is power, for sure. So say somebody has decided to, talk with their physician about their surgery. What are some questions that you think are good questions for them to ask their surgeon as they're going to begin that process?
Well, I think first of all, it's important to understand why the physician will recommend one thing or another. Certainly, the trend in treating breast cancer over the years has been to do less surgery, but you're still treating the whole breast. All these options I've talked about involve treatment of the whole breast. So the whole breast treatment is either done with a mastectomy or it's done with a lumpectomy plus radiation therapy. And we won't even get into where things are headed with radiation therapy. We don't have time to do all that today, but you need to understand why they're going to recommend what they're going to recommend. And basically, in order to do breast conservation, you've got to be able to remove the tumor with negative margins. That means no cancer is left in the breast that can be determined by pathology in the surgeon. You've got to make sure that the survival is going to be similar between the two. And lastly, you got to make sure you get adequate cosmesis, because the whole reason of going through that process is to maintain the breast and for it to look and feel as close to normal as possible. So if you've got those basic principles in mind, you need to ask the surgeon and the other physicians, how is my decision between one of these two options going to impact survival? And will I be able to meet those criteria? You got to make sure that your doctor has looked for other cancers in the breast, and they have. The mammography, ultrasound, MRI, whatever imaging device you're using is searching for that to make sure there's not any evidence of other cancers. You have to get the input from your surgeon in terms of the breast tumor ratio and whether that's going to give adequate cosmesis. Surgeons have got a lot of experience with doing that. They can tell when things aren't going to work out well in that regard. If you're going through reconstruction, then you need to speak with your reconstruction surgeon about what's the best option for me. Is it implant or is it autologous tissue? And autologous tissue is where something is removed from one part of the body, moved into the other. Most frequently, it's like a tummy tuck. And instead of throwing the tummy away, you put the tummy up and make a new breast. So all of these are options that are available, and you just need to inquire from your physicians, why are you doing this? What's the difference between having a mastectomy or having a lumpectomy radiation? What do you think my chances are that I'm going to need chemotherapy? And should that chemotherapy be given up front, and in other words, before the surgery, or should it be given after the surgery, which is a more common way of doing it? So the main thing to do is ask why. Just why are you recommending this? The thing that always made me nervous with patients was when they said, do what you want to do. Because I always wanted them to be involved in the decision-making process, because I think if they were involved in the decision-making process, then their satisfaction with the outcome was a lot better. They felt more comfortable that they were going to live. They felt more comfortable that they had the best cosmetic option done as well. So I think the most important question is why.
Yeah, and that being involved. Because like you were listing all of the different types of treatments and surgeries that you can have, how helpful would it be for you to know the difference so that you're not completely shocked, when you get something that you might have chosen differently had you been a little bit more, involved in the decision making.
Well, I don't think any physician expects the patients to be able to converse on the level that they do.
Right.
Uh, I did breast cancer work every day.
Hmm.
It just becomes second nature to you after a while, and that's not going to be possible with somebody who's brand new. Uh, Somebody comes out to my house to do work. I ask them why they're doing what they're doing. I don't expect to be able to understand what they're doing to the same level that they do,
Right.
but it enables me to understand what the process is and to live with whatever needs to be done.
Yeah. And it's kind of like our conversation a little bit. I know a lot of what you're saying, right, about the different procedures, but I know some people who might watch this video later, or even some who are on the call now who are new to this realm of treatment and breast cancer in general, might not necessarily understand the difference in those types of treatments. A lot of times people think about breast cancer, you just think, I don't have any boobs, I'm going to go through chemo and cancer is going to be gone. But it's bigger than that. There's still other decisions to make, there are still other options, and so as you're kind of naming these different procedures that a person could have based off of whatever is best for them in their particular treatment, can you kind of break down the different types of treatment for breast cancer? So the types of surgeries like the lumpectomy and the mastectomy and all of those types of
Sure.
things.
Um, a, a lumpectomy, the medical term for that is partial mastectomy. And what that means is the patient has an incision on their breast. At a point that's gives you the most direct access to the tumor. You go down into the breast and you remove that tumor with what looks like a normal rim of breast tissue around it. It obviously leaves a space in the breast, and the breast fills that with fluid and remodels it by itself over time. Usually combined with that is some sort of assessment of the lymph nodes underneath the arm. It used to be we removed all the lymph nodes. Then we got to where we removed only about 2/3. And now it's down to the point where it's possible to identify the first lymph node that cancer cells would go to. That node is removed, and then based on whether that node has cancer, whether it doesn't have cancer, you make decisions about what to do with the rest of the lymph nodes. And so initially, all that was done at one time. You would do a needle biopsy, confirm the diagnosis, you go to the operating room with the intent of removing the tumor from the breast and taking care of the lymph nodes. Now it's to the point where even if when the first lymph node is positive, you don't always have to have more lymph nodes removed.
Mm.
So now that has to be done on more of a delayed basis because the pathologist has to determine how involved this lymph node is with cancer so that you can make a decision about whether you need to go back and take more lymph nodes or not. So the simplest procedure for invasive breast cancer would be the lumpectomy and the sentinel lymph node biopsy, which is done simultaneously in one trip to the operating room. Depending on the information that you receive from that, plus all the imaging studies that need to be done, decisions are made about whether other therapies given like chemotherapy and radiation, that sort of thing. Take that one step further. Let's say the patient is not a candidate for lumpectomy and radiation and that they need to have a mastectomy. A mastectomy is removal of the breast. Simple mastectomy means that you just remove the breast itself. You don't remove any lymph nodes underneath the arm. When you do a mastectomy, you have the option of doing a reconstruction, or you may not, depending on what the tumor's like and the future therapy of it. Once again, something that multiple doctors get together and make the decision on. But when you do the mastectomy, if you do a reconstruction, that can be done either immediately or delayed. If you have an immediate reconstruction, then the surgeon can do the mastectomy in a way that conserves breast skin. By conserving breast skin, you're able to enhance the cosmesis. I used to tell the reconstructive surgeons, I'm the guy who's making you look good. But that reconstruction is done either with an implant or with tissue that's removed from, say, your abdomen and moved up. Once again, decisions that are involve multiple physicians discussing what the ultimate treatment plan is going to be. If they can't have an immediate reconstruction, then they will come back later If you come back later and have a delayed reconstruction, once again, the same options are available with implants versus your own tissue, depending on what works, going to work best in your particular situation.
I like how you broke it down. It's so simple. Appreciate that. Um, just because you hear these things, you just hear the name of whatever procedure might be recommended, and you'll be like, I have no idea what that
Mhm.
means and what that means for my body. And so when we have individuals, of course, who are going through breast cancer or cancer in general, of course, they have the families who love them, that want to support them. What are some ways that an individual who is debating whatever surgery is necessary for them, what are some recommendations that you might have for a family or a loved one who is trying to help this individual just lean into whatever care is best for them?
Well, I think first and foremost is when someone comes to you with cancer, any kind of cancer, but breast cancer in particular, plus all these options we talked about, it's always helpful to have a second pair of ears there.
Mhm.
Have a note taker, bring a scribe with you, take the notes. Um, I would always call the patients and tell them what the diagnosis was. And the reason is that if we told them just to come back in, the Dr. may want to talk to you, they knew what they had, and without hearing it from me. Um, but what that enabled me to do was to give them the diagnosis, let those wheels start turning. Because once I just said the word cancer, they didn't hear anything else I said the rest of the conversation.
Mhm.
But then the following day or week or whatever was convenient for them, we bring them back in. I always encourage them to bring somebody. Um, the other thing that needs to be done is in terms of taking notes and listening, it's just being supportive. I mean, there's a lot of things that I think patients go through when they get this diagnosis. I mean, they're worried about their own survivability, their own mortality, and they all live or
Mm.
um, how bad is this treatment going to be? I mean, am I going to get burned from the radiation? Am I going to be disfigured from the surgery? Am I going to lose my hair from the chemotherapy? All sorts of things worry them, the cancer. But then they're also worried about their family, their friends, their job. If how am I going to make ends meet if I'm working? And if I'm working and providing a lot of the income for the family, and I got to take all this time off from work, how are we going to make all this work? So there are a whole host of things outside the medical decision that need to be made that the family needs help with. And once again, you've got people there that you can bounce these things off of, get help from places like Forge. There's just all sorts of resources. But again, it's always good to have that support person there with you.
Yeah. Thank you so much, Dr. Shumate. Do you have any other final thoughts that you would like to leave our viewers with?
Well, I think the main thing is that the story of breast cancer is a success story. Success in that the survivability is improved, the functionality of the patients after their treatment has been improved. And not only is it a success story, but it's the story is still being written. And I anticipate that the successes are just going to continue to increase over time. We still have a lot of surgery involved with treatment of breast cancer. I'm not so sure that in the near future that there's going to be even less surgery done. There's going to be more local ablative techniques, less invasive biopsy techniques. So that I really think that this is going to, what's happened in the past is just going to continue to occur and happen in the future, and that the treatment's going to be better. The results in terms of survivability and function are going to continue to improve.
Thank you. I agree. I mean, medicine, technology, it's all just continuing to move forward. So, very hopeful for the future. I'm so thankful that you came to talk with us
Thank you.
today and you had some coffee with us during that coffee conversation. So, thank you for joining us, and we will see everybody soon.